Hi, my name's Heather Gregg. This is my presentation for the neurotransmitter of dopamine. In this presentation, I plan to discuss where dopamine is found in the brain, the neural pathways and receptors it uses, how an excess or a deficiency in the neurotransmitter can contribute to psychiatric illnesses. I'll discuss a specific disorder affected by my neurotransmitter and then provide you with my scholarly references. So to start out, where's dopamine found in your brain? So the dopamine cell bodies are located in the substantia nigra, where they project into the stratum and into the ventral tegmental area. And at that point, they project into the frontal and cingulate cortex. This is your mesocortical pathway. The striatum, the hippocampus, and other limbic structures make up our mesolimbic pathway, and dopamine nuclei are also located in the hypothalamus and project into the pituitary. And all of these pathways are noted here on the screen that you can see how they travel through those areas of the brain that I talked about. The life cycle of dopamine starts similar to the life cycle as epinephrine. We need to have some type of neuron that can actually produce this neurotransmitter dopamine. With dopamine, tyrosine has to move into the cytoplasm. This occurs via active transport. Once tyrosine is in the cytoplasm, it converts into dopa by tyrosine hydroxylase. Dopa then has to be converted into dopamine with the enzyme decarboxylase. VMAT transfers dopamine into the vesicle. Once it's in the vesicle, it can be stored in the terminal and it can be released into the synaptic cleft when the transmitter is activated. We have 5 different transmitters, 5 different receptors that dopamine works on. So our 5 receptors are D1, D2, D3, D4, D5, all of which I have listed on this slide. Each of these receptors has a different function and is found in different locations. So our D1 is going to be memory, attention, impulse control, regulation of our renal function, locomotion. D2, locomotion, attention, sleep, memory, learning. D3 is cognition, impulse control, attention, and sleep. D4 is cognition, memory, fear, impulse control, attention, and sleep. And D5 is decision making, cognition, attention, and renin secretion. When we look at the effects of dopamine, we have to remember each of those receptors and what those receptors do. Because if we have a stimulation, we're going to have an excessive amount, or if we have a lack, we're going to have a decreased amount. Since dopamine is so much involved with our fine motor movement, it's important for our emotions and our thoughts and our decision making. When it's too low, we can have symptoms that are seen like in Parkinson's. So we're going to have some tremors, some bradykinesia, some shuffling gait, postural instability, schizophrenia. The negative symptoms that we see are caused by low levels of D1. And then if we have too much dopamine, then all of those receptors are going to have increases, which is going to create our positive symptoms that we see in schizophrenia, like hallucinations, delusions, disorganized speech, bizarre behavior, and catatonic behavior. So I'm going to further discuss schizophrenia, since either an excess or a deficiency in dopamine can cause this. McCanson-Hewler describes schizophrenia as a thought disorder that reflect a break between the cognitive and emotional sides of a personality. No 2 patients are going to have the same symptoms with schizophrenia. However, all the symptoms of schizophrenia can be classified as positive, negative, or cognitive. A current view of the dopamine hypothesis of schizophrenia is that dopamine pathways are altered in two different ways. As noted on the prior slide, an excess production of dopamine can lead to our positive symptoms that would result in our hallucinations, our delusions, our thought disorders, and our bizarre behaviors. Negative symptoms and cognitive alterations in schizophrenia result in that reduced dopamine transmission, and this is in the mesocortical dopamine pathway. Examples of your negative symptoms are your affect, flattening, anhedonia. And then we can also have cognitive symptoms with this lack, and that would be a reduced insight, difficulty paying attention, and problems with our working memory. And when we're going to be treating that, we need to understand whether our patient is having positive symptoms from too much dopamine. So now we want to block the dopamine, or are we having negative symptoms because if we have not enough dopamine, and then we might need to increase the dopamine production. And this can be done with our antipsychotics. And the references that I used for this presentation are here, and I hope you enjoyed my presentation. Thank you.